What is the Roux-en-Y gastric bypass? It's a combination of restriction and duodenal exclusion. So it is advantageous in compared to the band and the sleeve, but as we'll show, it's disadvantageous in comparison with the MGB. So the Roux-en-Y gastric bypass combines obstructive restriction, which over time enforces a pathologic diet into the patient. But it has minimal fatty food intolerance and fat malabsorption because the length of the biliopancreatic limb is relatively shorter. The obstructive restrictive procedures, which include the Roux-en-Y, the band and the sleeve, and the old vertical banded gastroplasty, successfully block the intake of a normal healthy diet. But they do not block the intake of liquids, soft calories, and so-called junk foods. And thus, over time, the patient learns that certain healthy foods lead to nausea and vomiting, discomfort, gastritis, and irritation, whereas junk foods or liquid calories, if they sip them over time, can allay their desire for food. Unfortunately, these foods are high-calorie, poor choices, and tend to lead to weight regain. Since there is a bypass in place, the contribution of malabsorption to the reduction of energy after Roux-en-Y gastric bypass has been studied, particularly Elizabeth Odestrel et al. In October 2010 published a paper where they looked at this issue in particular. Particularly their study of the contribution of malabsorption to the reduction in net energy absorption after a long limb Roux-en-Y. The results showed that the Roux-en-Y had no significant effect on the absorption of protein or carbohydrate meals given after Roux-en-Y. 5 months after bypass, malabsorption was only approximately 100 calories per day, whereas the obstruction and the restriction of food intake reduced energy absorption and intake by more than 2,000 calories per day. So that in comparison, the malabsorptive effect of the Roux-en-Y was almost 20 times, or 1/20th, that of restriction. So restriction 20 times more powerful than malabsorption early on after the Roux-en-Y bypass. 14 months later, caloric intake was increasing, so that the restriction measured at 5 months 2,000 calories of estimated intake had dropped to only 1,500 by 10 months later. What this means is already the Roux-en-Y restriction is beginning to fail. Thus, we can conclude several things. That although the duodenal exclusion contributes to the effectiveness of the Roux-en-Y, the Roux-en-Y's effectiveness is primarily because of its restriction on intake. It has, as the teachings from many of the leaders for the performance of the Roux-en-Y, that it must have a small pouch with a tight obstructive Gastro-Jejunostomy. In this study, even with a long limb Roux-en-Y bypass, the Roux-en-Y shows early signs of Roux-en-Y caloric restriction failure. And the primary mode of effectiveness of the Roux-en-Y is through its obstruction. New paragraph, new section. A review of the history of gastrointestinal and general surgery to see what has been forgotten and what we can recall into the reader's mind to teach what we can expect in the outcomes of the mini-gastric bypass, which is based on 100-year-old surgical procedures. In short, what have we learned from 100 years of gastrointestinal, parentheses, GI surgery, close parentheses? We have studies about the operations performed on the stomach and the intestine for the past 100 years. For the next few comments, we're going to refer to studies by Everson in 1954, McLean in 1954, and Woodger in 1963. basically, we're going to talk about the fact that we know a lot about the GI tract after surgery. So we know about what's called post-gastrectomy results because for the past 100 years, we've done partial gastrectomies. We've also done total gastrectomies and subtotal gastrectomies, but those are not part of our purview today. We're talking about distal partial gastrectomies because that is analogous to the mini-gastric bypass physiology. In fact, if the surgeon is clear in his knowledge and background, it will be clear that, in fact, the mini-gastric bypass is analogous to the old antrectomy in Billroth 2. That is to say, a portion of the stomach has been excluded, in this case bypassed as opposed to resected, and a portion of the small intestine has been bypassed to create a connection on the end-to-side Billroth 2 loop Gastro-Jejunostomy. So again, the knowledgeable surgeon will understand that the antrectomy in Billroth 2 is an analog of the mini-gastric bypass. And if one will remember the history of post-gastrectomy, antrectomy, Billroth 2 type operations, it will help the surgeon understand what to expect in the outcome of the mini-gastric bypass. So from these studies back in the 50s, we know a few things. One is that the MGB and these types of gastrectomy in the past have been around for over 75 years. And what we know is post-gastrectomy patients, those ulcer patients or gastric cancer patients or trauma patients who've had the antrum removed and had the gastrointestinal tract reconstructed using a Billroth 2 or Billroth 1 type connection teaches us something about the new modified gastrointestinal tract. And what it teaches us is something that every general surgeon should know inside and out, and that is post-gastrectomy, Billroth 1 and Billroth 2, that there is sweet and fatty food intolerance. It is common and it has a name, quote, post-gastrectomy syndrome, close quotes. And the studies, all studies show very clearly that this post-gastrectomy symptomatology is more common after Billroth 2 than after Billroth 1. So we can think again analogously that the Billroth 1 is in some ways like the sleeve gastrectomy, whereas the Billroth 2 is more like the antrectomy in Billroth 2 that's present in the mini-gastric bypass. But again, there are several things that we should learn from the past 100 years that we recall to the mind of the surgeon who's reading this article. One, that the antrectomy in Billroth 2 can be done well and frequently, but the Billroth 2 often induces a post-gastrectomy syndrome where sweets, fatty foods, and liquid calories are relatively intolerable to the patient. And so they must modify their diet because, after the Billroth 2 in particular, they suffer from post-gastrectomy syndrome, either completely or in form thrust versions. Post-gastrectomy syndrome is the foundational principle of the mechanism of action of the mini-gastric bypass. Again, what do we know from 100 years of GI surgery? We know that sweets and fatty food intolerance is rare after gastro-jejunostomy alone. It's rare after vagotomy alone. It's rare after Roux-en-Y, and it's rare after Billroth 1. But as Butler, B-U-T-L-E-R, Butler published in 1961, this syndrome of post-gastrectomy syndrome of sweets and fatty food intolerance after gastric operations is especially common after Billroth 2. And more importantly, for the surgeon who is considering the mini-gastric bypass, it's especially common after the Polya type gastro-jejunostomy. It's especially common after the Polya, P-O-L-Y-A, Polya type Billroth 2. See Butler, 1961. And we'll show a figure of the Polya Gastro-Jejunostomy. The Polya Gastro-Jejunostomy, we remind the reader, is unique as far as the connections and the gastro-jejunostomies that we perform because of the very large gastro-jejunostomy. In comparison to others, it includes almost a complete hemisection of the antral body junction of the stomach. And this in particular, because of the rapid gastric empty, leads to the symptoms of intolerance to sweets and fats, and that is the foundational principle of the gastro-jejunostomy and the pouch in the MGB. How many times have bariatric surgeons misunderstood this portion of the MGB? Period, paragraph, new section. Bariatric surgical procedure problems. Again, reviewing the other surgical procedures, the vertical banded gastroplasty has been abandoned. It failed. It resulted in weight regain. The lap band is nearly abandoned. A few people continue to use it, but it leads to failure and weight regain. And a significant number of patients have acid reflux, and a few esophageal cancers have been reported. The sleeve is relatively newer in its course, but appears to be following a course similar to the vertical banded gastroplasty and the lap band. We are now seeing weight regain, new onset of GE reflux, and the first few cases of gastroesophageal cancers. The Roux-en-Y, of course, is, quote, the gold standard, close quote. It's unequivocal that the Roux-en-Y has the highest risk of complications. It has the highest difficulty in performance in comparison to these other operations. It has the unique and dangerous and deadly complication of a relatively high risk of internal hernia with bowel obstruction and occasionally death. And it has weight regain to such an extent that surgeons have invented a new version of the Roux-en-Y, the banded Roux-en-Y, to deal with its problems. Finally, we have the massive bypass surgeries, the BPD, duodenal switch, and SATI, etc. We know these cause malnutrition, deficiencies, diarrhea, foul-smelling gas, and are very rarely used except for newly interested surgeons. But their disadvantages are many, despite the fact that they do cause significant weight loss. That's the end of part 3 at slide 28.